Good day to you all. Today I'm going to talk about muscle relaxant. I am Dr. Yasser Osman, a professor in anesthesia department. Muscle relaxant is the second step in performing induction of general anesthesia as discussed before in a previous lecture. There is two types of muscle relaxant available. The depolarizing muscle relaxant, example of it is the Suxamethonium or succinylcholine, another name for it, or the non-depolarizing blockade, which is the pancuronium, pipicuronium, rocuronium, vicuronium, atracurium, CIS-Atracurium, and mivacurium. Now, we have to talk about a little bit of the physiology of the neuromuscular junction in order to understand the difference between the two types. First, when there is a muscle contraction order, there is a nerve impulse that travels through the nerve fibers. This nerve impulse will cause the acetylcholine vesicles to release its acetylcholine in the synaptic cleft. Then the acetylcholine is attached to the acetylcholine receptors here, causing the muscle to contract. Then quickly, acetylcholinesterase that is present in the synaptic cleft will react with the acetylcholine, causing it to its removal from the acetylcholine receptors, hence rendering it possible to re-excite again by another nerve impulse with the same process. The repeating of the nerve impulses and the repeating of the excitation of the acetylcholine to the acetylcholine receptors causing the muscle to continue its contraction. Well, anything that interrupts this process will cause muscle relaxation at the end. In the depolarizing muscle relaxant module, the drug looks the same as the acetylcholine, but it is not hydrolyzed or taken by the acetylcholinesterase in the synaptic cleft. It is rather taken by the pseudo-acetylcholinesterase or the plasma acetylcholinesterase that is present in the plasma. This makes it more difficult for the succinylcholine to leave the acetylcholine receptors. Hence, it will cause initially muscle contraction or what we call fasciculation, then by its continuous presence on the acetylcholine receptor, the muscle will be in a flaccid or paralyzed state till the receptor is free again from the muscle relaxant and capable of contraction again. In the non-depolarizing muscle relaxant module, the non-depolarizing muscle relaxant is attached to the acetylcholine receptor, but it does not cause any excitement for the muscle, and so it blocks the effect of the acetylcholine released in the synaptic cleft by competitive inhibition. So it competes with the acetylcholine on the receptor site, but it does not cause any excitement of the muscle fiber, so the muscle fiber will remain flaccid. Well, we are going to talk about the first example, the depolarizing muscle relaxant or the succinylcholine as an example. It is characterized by rapid onset with muscle fasciculation, as we have explained before. It is metabolized by the plasma cholinesterase or the pseudo-cholinesterase that is present in the plasma and not the cholinesterase that is present in the synaptic cleft. It is a D-choline ester of the acetylcholine. It is presented in a clear colorless aqueous solution in ampoules with 100 mg in a 5 ml solution. It is stored in the refrigerator at 4 degrees centigrade. The dose is 1 to 2 mg per kg as a bolus dose. It has no antidote. It is effective within 30 seconds and lasts for several minutes only. Its effect on the CNS causes small increase in the intracranial pressure that is of some relevance in a head injury patient. On the CVS or cardiovascular system, it increased the blood pressure and caused bradycardia. It also increased the intraocular pressure and intragastric pressure and lowered the esophageal sphincter pressure. Elimination, it is metabolized by the plasma cholinesterase, as we have said, and complete recovery occur in 10 to 12 minutes. Indication of this drug, it is very suitable for situation needing rapid onset and or short duration of action. It is used in tracheal intubation, which is the drug of choice if there is a risk of pulmonary aspiration. Example, in cases of patient with full stomach or emergency operation. Also, it is used in tracheal intubation in expected difficult airway patient. Short procedure needing relaxation, and in obstetrics, especially before the delivery of the baby, to relieve severe laryngeal spasm, electroconvulsive. What about the side effects? Cardiovascular effects, it include blood pressure will be increased, bradycardia, and even asystole, especially in children, and this can be prevented by atropine. Muscle fasciculation, and this muscle fasciculation will cause some of the following problems: post-operative muscle pain, increased intraocular pressure, this is due to contraction of the extraocular muscles, which is dangerous in case of open eye surgery. Increased intragastric pressure due to the fasciculation of the abdominal muscle. Increase the intracranial pressure and hyperkalemia, especially in cases of burn, tissue trauma, and nerve injuries. Malignant hyperthermia, succinylcholine is one of the triggering drugs for this phenomenon. And sometimes it causes prolonged apnea. This is due to abnormal or absent in the plasma cholinesterase. And this is determined by genetics. Lastly, it can cause histamine release and anaphylaxis. Contraindication is malignant hyperthermia, susceptible patient, condition associated with excessive release of potassium, example, recent burn and tissue trauma, and myotonia. Non-depolarizing blockade. Mechanism of action. As we have discussed before, non-depolarizing neuromuscular blockade is the result of competitive occupants of the post-junctional receptor, preventing acetylcholine from reaching the receptor. This process is competitive and reversible. The block can be antagonized by a local increase in acetylcholine as produced by anti-cholinesterase. The muscle relaxant have no intrinsic activity at the neuromuscular end plate, so it does not cause any fasciculation. Some examples is Atracurium. It's a clear, colorless aqueous solution provided in 2.5 and 5 milli ampoules, 10 mg per milliliter, stored in the refrigerator. The dose is 0.5 mg per kg as bolus. Initial dose lasts 30 minutes and onset of action is from 2 to 3 minutes. Short duration and lack of cumulative effect thus can be given by continuous infusion. Has no increase in the intraocular pressure effect or intracranial pressure. Has minimal cardiovascular effect, and it is non-cumulative and do not depend on liver or kidney for elimination, but rather it depends on what is called Hofmann elimination and ester hydrolysis, which is a spontaneous degradation at body pH and temperature of that drug. It is the drug of choice in renal or hepatic failure because of that reason. Side effects, the most important one is the histamine release and can cause bronchospasm, hypotension, and erythema or wheals, generally on the whole body or along the vein that was used to inject the drug in. CIS-Atracurium, it's an isomer of atracurium, hence the name CIS. The features are as of atracurium except the dose is IV bolus dose 0.15 mg per kg and the duration of action is between 30 and 45 minutes. The onset of action is about 3 to 0.5 minutes. And the most important advantage, it has no histamine release. Pancuronium. It's a colorless aqueous solution. Dose IV bolus 0.08 to 0.1 milli per kg. Initial dose lasts 45 minutes to 60 minutes and onset of action it starts after 3 to 5 minutes. Useful in lung operation. It does not cross the blood-brain barrier and does not increase in the intraocular pressure and the intracranial pressure. CVS increases in the heart rate and cardiac output and blood pressure due to vagolytic action. Elimination mainly by the kidney 80%, 10 to 20% metabolized and excreted in body. Rocuronium is a recent steroid relaxant, also presented in an aqueous solution, 5 and 10 milli ampoules. Each ampoule contains 10 milligram per milliliter as a concentration. Stored also in the refrigerator. The dose is 0.4 to 0.6 milligram per kg as bolus intravenous dose. It has an intermediate duration of 30 to 40 minutes. It is the most rapid onset of the non-depolarizing muscle relaxant, useful for rapid tracheal intubation. It has no CNS effect and no significant cardiovascular effect and has no histamine release. Elimination mainly unchanged in urine and bile. Hepatic or renal failure can cause prolongation of its effect. Rocuronium Bromide dose, IV bolus dose 0.05 to 0.1 milligram per kg, can be used by continuous infusion. The infusion rate is 0.05 to 0.1 milligram per kg per hour. Initial dose lasts 25 to 40 minutes, has no CNS effect, i.e. it does not increase in the intracranial pressure, and has no cardiovascular effect. Also, it does not cause any histamine release, but it is eliminated by hepatic metabolism. Eliminated mostly unchanged in bile and up to 35% in urine. So the action is prolonged in patient with liver diseases. It is suitable in patient with absent renal function. Reversal of the non-depolarizing blockade. It is necessary to completely and totally terminate the action of the non-depolarizing muscle relaxant before extubating the patient in the recovery stage of general anesthesia. To ensure this, an antidote to non-depolarizing muscle relaxant should be given to the patient. We have two main categories that we use as an antidote for this type of drugs. The anti-cholinesterase drugs, its mechanism of action: the drug prevents the normal hydrolysis of acetylcholine by acetylcholinesterase enzyme, thus allowing it to accumulate and compete with the neuromuscular blocking drug at the receptor site. Thus, the neuromuscular transmission will return towards normal. This drug works both at the nicotinic site, at the motor end plate, which is the desirable effect of the drug, and the muscarinic site, the organ innervated by vagus, which is the side effects. The muscarinic side effects include bradycardia, increased secretion and intestinal peristalsis, and bronchospasm. These effects can be blocked by vagolytic agent as atropine or glycopyrrolate, given at the same time with this drug. Example of anti-cholinesterase drugs is neostigmine. Doses in adult 2.5 milligram, maximum 5 milligram, i.e. we repeat the dose twice, plus atropine 1.2 milligram, and this is the most commonly used to reverse the action of the non-depolarizing muscle relaxant. Both drugs are given mixed together and given slowly IV. The other choice is the Sugammadex. Sugammadex is a new reversal agent used for rapid and full reversal of rocuronium and to a lesser extent vicuronium and pancuronium only. Each Sugammadex molecule binds a molecule of rocuronium to form a tight 1:1 water soluble complex. resulting in a movement of the muscle relaxant away from the neuromuscular junction into plasma down a concentration gradient. It is excreted unchanged in urine. Sugammadex can reverse the effect of the rocuronium within a few minutes, even when given a few minutes after the neuromuscular blocking drugs. It is free of side effects. It does not depend on renal excretion. It results in rapid reversal with no residual postoperative weakness. So it may serve as life-saving measure in patients who receive this relaxant for intubation and who cannot be ventilated or intubated. Thank you.